Hello, I am Dr. Lakshmi Kumar. I am an interventional radiologist at Pace Hospitals, Hyderabad. Today we will discuss about role of interventional radiology in HCC management. So HCC means hepatocellular carcinoma. It is a type of liver cancer. In fact, it is the most common type of liver cancer. So it originates from the liver's main cells. So the most number of cells in the liver are the hepatocytes. So it originates from those hepatocytes. The HCC is commonly seen in patients with chronic liver disease or cirrhosis. So the risk factors for these diseases are the alcohol abuse, presence of hepatitis B or hepatitis C viral infection, fatty liver disease. So these are the major risk factors. There are several risk factors for HCC, but these are the major risk factors. So HCC patients can present with different non-specific symptoms like distension of abdomen, means swelling in the abdomen, or jaundice. You know what is jaundice? Yellowish discoloration of eyes and urine. So that is one symptom. They can present with loss of weight or loss of appetite. Sometimes they can present with blood in vomitings or blood in stools or black colored stools, or some other non-specific symptoms like feeling of weakness or fatigue. So these are all the symptoms of HCC. So HCC is commonly diagnosed by imaging tests, means by scanning. Usually CT or MRI scan is done. Also other supportive tests like blood investigations like AFP levels can be used to support the diagnosis. And if the imaging, that is the scan features, are not typical, then we may need a biopsy. And also we can do some molecular testing on those biopsy sample for better treatment. So these are all the ways to diagnose the HCC. So there are several treatment options available for HCC, like liver transplant, surgical resection, that means removing the tumor by surgery. Next, interventional radiology treatments, chemotherapy, immunotherapy, radiotherapy, and also best supportive care, internal stage. So for HCC patients, the best treatment available is the liver transplant, because liver transplant not only removes the tumor from the liver, it also removes the diseased liver. That means the HCC usually develops in patient with cirrhosis. So the entire liver is not good, it's damaged. So the HCC can develop in any part of the liver. So if you treat only the tumor, in future other part of the liver may develop a new tumor. So that's why in transplant is what happens is they'll remove the tumor and also the diseased liver and they place a new liver. So that is the best treatment option. And the second best is the removal of the tumor by surgery. So these are the best treatment options, but unfortunately most of the patients are not eligible for these treatments, because for liver transplant there is scarcity of donors, and for surgical resection most of these patients have so many diseases, so that makes them a high risk candidate for surgical resection. So that's why the next best treatment option available is the interventional radiology treatments. So interventional radiology treatments can cure the tumor completely in early stages. In intermediate and late stages, we can prolong the survival of the patients by reducing the growth of the tumor or decreasing the tumor burden. Also, if there is a small tumor in a patient and right now he is not having a donor, then in those patients we can treat the tumor and give time for the patient so that tumor will not progress into advanced stage. So if the tumor progresses into advanced stage, then it becomes ineligible for transplant. So that's why we can treat the tumor and prevent it from progressing to the advanced stage. So that is called bridging. So we can bridge the patient, we can give time to the patient to undergo liver transplant. Also, if the tumor is in intermediate or some cases in advanced stages also, we can downstage the tumors so that it comes into the early stage, and we can decrease the burden of the tumor so that the patient becomes eligible for liver transplant. So these are the various roles of interventional radiologist in HCC treatment. So interventional radiology treatments can be broadly divided into two categories. First is the percutaneous ablation treatment. Second is the transarterial treatment. So in percutaneous ablation treatment, what we will do is, under image guidance, we will place a needle through the skin into the liver and will reach the target, that is the tumor in the liver. So once we reach the tumor, then we will destroy the tumor using various methods. So the most common ones are the radiofrequency ablation and the microwave ablation. In these two, we will generate more heat near the tumor, and this heat will destroy the tumor cells. Also, there is cryoablation, in which we freeze the tumor to excessively low temperatures so that the tumor will die. There are other non-thermal techniques like irreversible electroporation and also histotripsy. So these are all the percutaneous ablation techniques. And the transarterial therapies. In transarterial therapies, the common ones are two types. One is TACE, transarterial chemoembolization. In transarterial therapies, what we will do is, we reach the tumor feeding arteries, means the blood vessels which are supplying blood to the tumor. We reach those blood vessels from the thigh artery or the wrist artery, and we reach there using small thin pipe called catheter. So through that catheter we will inject in TACE two combinations. One is blood flow blocking agent and second is the chemotherapy agent. So we use both these substances at the tumor site so that it will act only on the tumor, so that there is no systemic side effects like in the systemic chemotherapy. In general chemotherapy, what they do is they give chemotherapy medicine through IV or orally. Then it will circulate throughout the body most of the times, causing many systemic side effects, means whole body side effects will be there. Whereas in this treatment, there is only a treatment given to the tumor, not the entire body. So the systemic side effects will be less. So that is TACE. So second is TARE, transarterial radioembolization. In this, what we will do is, we will inject small radioactive beads similar to TACE, but here instead of chemotherapy drug and artery blocking agent, we will inject radioactive beads. These radioactive beads will go and settle inside the tumor, and they will emit radiation locally, and they will destroy the tumor. So this radiation will only be limited to the tumor, and it will not affect any part of the liver outside the tumor. So these are the various treatment options available by interventional radiologist for the treatment of HCC. So the various interventional radiology treatments like ablation and transarterial therapies, they can be selected based on the stage of the tumor. If the tumor is in very early stage, like less than 3 centimeter, then mostly we will do ablation, either RFA or microwave ablation. So that is one thing. If the tumor is larger, between 3 to 5 centimeter, commonly we will do combination of TACE and ablation. So that will destroy the tumor. If it is more advanced, like it is in an intermediate stage, so in intermediate stage, the treatment of choice as per interventional radiology is concerned is the TACE, so transarterial chemoembolization. And in patients with a little more advanced tumor, in which a large vessel in the liver, large blood vessel in the liver is involved by the tumor, in those cases commonly we do TARE, that is transarterial radioembolization. So in advanced stages, one more thing what we do is we commonly combine with immunotherapy and TARE or TACE, and that will improve the survival of the patient. So this is how we select the type of interventional radiology treatment based on the stage of the tumor. Also, before selecting a type of treatment, we'll assess the liver function and the performance status of the patient. So the liver function is assessed based on the blood tests like LFT, bilirubin, albumin, and the performance status is assessed based on assessing the patient whether he is able to perform his daily life activities on his own or not, whether he is able to perform strenuous activities or not. So if the patient is in terminal stage, means the liver function is very bad or is in poor performance status, then only treatment unfortunately that we can offer for these patients is best supportive care. There is no immunotherapy or any interventional radiology or surgical treatment that we can offer for these patients. For other patients, as we have discussed, depending on the stage, we can offer the interventional radiology treatments. Yes, as we have discussed, interventional radiology treatments can be curative for HCC, particularly for very early and early stages. Also, in some cases of intermediate stage and in some advanced stages also, we can cure the patients almost completely, the tumor wise. Okay, with ablation, TACE, combination of TACE, TARE and systemic therapy and radiotherapy. So we can cure some of the intermediate and advanced HCCs also, and most of the early stage and very early stage HCCs. So commonly for percutaneous ablation, we use either ultrasound and CT or both ultrasound and CT guidance, so that we can visualize our needle in real time, where it is going, whether it has reached the target or not, and how is the ablation going on, is the entire tumor is getting ablated or not. So these all can be monitored under ultrasound and CT guidance. So whereas for transarterial therapies, we generally do it under X-ray guidance or fluoro guidance. So these are the imaging techniques that we generally use. So generally these are very low risk procedures. So after ablation or transarterial therapies, generally the patients can resume their daily activities within 24 to 48 hours, and even the strenuous activities can be started mostly within a week or mostly after 5 days. So that is the typical recovery time, and usually feeling of nausea or slight fever and abdominal pain after these procedures, which will usually recover in a few days time, like 3 to 5 days. This is the typical recovery period after the interventional radiology treatments. So the type of anesthesia is dependent on the type of procedure that we are doing. Mostly the ablation procedures are done under conscious sedation, means you will not feel any pain, but you will understand what we are talking, but you will not be able to respond. So that is called conscious sedation. You will understand what we are talking, but you cannot move and you cannot experience pain. So that is the usual anesthesia that we use. Whereas in patients with a tumor in high risk location near the critical structures, in those cases we generally use general anesthesia, and also in a type of ablation called irreversible electroporation, we generally use general anesthesia. Whereas the transarterial therapies are usually done under local anesthesia. Also, the type of anesthesia is dependent upon the patient's preference. Like the patient, if he or she is very sensitive to pain or anxious, and then in those cases we generally prefer general anesthesia. So that is also a factor that we consider while choosing the type of anesthesia. Yes, as the interventional procedures are mostly low risk, we can repeat the procedure if at all there is a recurrence of HCC. So again, in the patient with recurrence, we'll again assess the liver function, performance status of patient, and what is the size of the tumor, whether there is any invasion of the liver blood vessel or any extrahepatic spread, means spread outside the liver. So these are all factors we again consider before choosing the type of treatment. So generally for these patients, although they are unfit for surgery, they will be mostly fit for the interventional procedures, either percutaneous or transarterial therapies. Very rarely we will encounter patients with contraindications, like as we have discussed, patients with poor liver function or very advanced liver cancer that has spread outside the liver so much. So these are the contraindications. Also, if the patient has active infection, that is also a contraindication for interventional radiology treatments. And patient with poor performance status also is a contraindication. So the success rate for cancer patients is generally described in terms of the number of years patient can survive after the treatment. So for HCC patients in early stage or very early stage, most of the patients will survive more than 5 years. Whereas in intermediate stage, that is more than 5 centimeter or multiple liver tumors with TACE or tear, the survival is usually more than 2.5 years. Whereas in advanced stage with invasion of liver vessels or spread outside the liver, so these patients, the survival with systemic therapy plus TACE or tear is generally more than 2 years. So whereas in terminal stage patients, the only treatment that we can offer is best supportive care. So in those patients, the survival is hardly 3 months. So this is how the success rate of various treatments for HCC patients. So as we have previously discussed also, if the patient is having advanced HCC where a liver blood vessel is also involved by the tumor, or there is some limited extrahepatic spread, means only 1 or 2 sites outside the liver are involved by the cancer. So in those cases, what we will do is we generally do combination of treatments. So we use TACE or tear plus radiotherapy plus immunotherapy. So that gives a best treatment that we can give that can improve the survival of the patient. So in some cases, we can almost cure the advanced HCC also and make them fit for liver transplant also. After any interventional radiology treatment for HCC like ablation or transarterial therapy, we generally image with CT or MRI 4 to 6 weeks after the treatment to assess the response to the treatment. So if it is completely responded, then we will follow it up after 3 months. So we'll image every 3 months till 2 years, and then every 6 months. That is the follow-up of these patients. So there are 2 types of prevention. One is primary prevention, second is secondary prevention. Primary prevention means before occurring HCC, or how to prevent liver disease from happening. So one is abstaining from alcohol and quitting smoking, and third is maintaining a healthy weight. So these are the major ways that we can prevent liver disease. So other things like getting vaccine for hepatitis B and getting screening for hepatitis C. That means getting tested for hepatitis C, whether it is present for you or not. So, and if at all it is present, then getting early treatment for hepatitis C. So that can also prevent HCC and liver disease. And diet rich in minerals and vitamins like vegetables, fruits. So that is one thing that you can do. And preventing intake of aflatoxins. Aflatoxins can develop in improperly stored nuts or grains. So that is also one way to prevent HCC or liver disease. And in those patients who already have liver disease, either cirrhosis or chronic liver disease, how to prevent HCC in occurring in those patients is by regular surveillance. That means getting ultrasound and blood test, that is AFP levels, every 6 months, and if required CT or MRI in those cases in whom the liver or the liver lesions are not quite well visible on ultrasound. In those cases, getting CT or MRI. So these are the ways that you can use to detect any early tumor developing in those patients with the CLD or cirrhosis. So if the tumor is detected in early stage, then as we have discussed, we can almost cure the tumor in most of the cases. So that's why surveillance, that is routine screening of patients with CLD or cirrhosis, is vital to improve the survival and increase the lifespan of these patients. So thank you for your patient listening. So if you have any further queries, we are very happy to answer your queries. Please feel free to reach us. Thank you.